third degree heart block or the complete heart block. Uh, in order to understand the complete heart block or the third degree heart block, which is last one in understanding of the heart block, we need to understand that there are three parts of the impulse transmission in the conduction pathway of the heart. The part one is related with generation of the SA node impulse automatically. SA node automatically generates impulses, and these are transmitted to the atrial muscle through the Batchman tract. And once in the atrial muscle, these impulses cause the depolarization of the atrial muscles. This depolarization of the atrial muscle causes the generation of the P wave. In the PQRS-T complex, the generation of the P wave is because of the first part in the conduction of the impulse into the atrial muscle. Generated automatically in the SA node, goes through the Batchman tract, enters into the atrial muscle, causes the depolarization of the atrial muscle, which generates a P wave. So, a very important point to remember is that the generation of the P wave is before the impulse even enters into the AV node. This is an event happening before the entry of the impulse into the AV node. In the second part, the impulse from the atrial muscle enters into the AV node, and this entry is actually in order to delay the transmission of the impulse from the atria to the muscle. So, in order for the filling of the ventricular muscles prior to the atrial depolarization. So, there should be a delay between the atrial and ventricular depolarization. So this AV node delay is depicted on the ECG paper as a PR segment. The definition of the PR segment is from the end of the P wave to the start of QRS complex. This is different from the PR interval, which is from the start of the P wave to the start of QRS complex. So second part of the impulse transmission is when the when the impulse enters into the AV node and causes a delay. The third part of the impulse transmission from the SA node to the ventricle is when the impulse enters from the through the AV node into the bundle of His. Then it first goes to the gives the septal branch, and then it simultaneously enters into the right bundle branch and left bundle branch. There are two fascicles of the left bundle branch, anterior and the posterior fascicles, and the at end of the right and left bundle branches there are Purkinje fibers, and through from the Purkinje fiber this impulse enters into the ventricular muscle and causes the depolarization of the ventricular muscle, which generates QRS complex. Now we need to remember that two or three important factor that once the impulse enters into the bundle of His, again it is a very fast event. It rapidly moves from there up till it causes the depolarization of the ventricular muscle. First thing. Secondly, if there is some sort of blockage or problem at the level of the AV node, it will not be affecting P wave, because P wave is generated by the atrial depolarization, which is an event happening before the entry of the impulse at the AV node. Why we are mentioning it here? Because in the complete heart block or third degree heart block, AV node is completely blocked, so it will not affect the regularity and the generation of the P wave. So this is a very important factor to remember. We know from the rhythm of the heart that normal rhythm of the heart is normal sinus rhythm, and that means that SA node, sinoatrial node, is pacing the heart. SA node is the pacemaker of the heart, but in fact there are three pacemakers in the heart. One is SA node, which generates impulses at a rate of 60 to 90 per minute, which causes the heart rate of 60 to 90 beats per minute, and it generates a narrow QRS complex. That means less than three small boxes or less than 0.12 second. But there are two other pacemakers in the heart. One is AV nodal pacemaker or junctional pacemaker, which generates impulses at a rate of 40 to 60 times per minute, and which creates pulse of 40 to 60 beats per minute. It can be narrow or complex depending upon its location in the AV node or junction between the atria and the ventricle. If it is located at a higher up location in the AV node, it would generate 40 to 60 beats per minute, and the QRS complex would be narrow. But if the location of the AV nodal blockage is at the level of the bundle of his or lower part of the AV node, then the junctional pacemaker would be making or generating broad QRS complexes more than three small boxes in duration or more than 0.12 second in duration. There would be a regularity of the QRS complexes, but these would be broad and these would be 40 to 60 times per minute. And the last one is the ventricular pacemaker, which is located in the Purkinje fibers, and it generates a broad QRS complexes which are more than 0.12 second or more than three small boxes. The number of the impulse generation is 20 to 40 per minute, or pulses are generated at a rate of 20 to 40 beats per minute, and complexes are broad. They are broader than three small boxes, and these are the ventricular pacemakers. Why we have SA node actually as a driving pacemaker? Because it generates more number of the impulses, though, so the heart as a organ is happy with the one pacemaker generating more number of the beats, so the heart can generate a blood pressure well enough to sort of like give a proper circulation to the body. So the rest of the two are dormant most of the time, as long as there is no AV nodal complete blockage. And whenever there is complete blockage of the AV node, then it depends upon the location of the blockage. If it is located higher up in the AV node, the junctional pacemaker would be activated. If it is located at the lower part of the AV node, the ventricular pacemaker would be activated, and atria and ventricular would be contracting or depolarizing very independently. There would be P wave and there would be QRS complexes. P to P interval would be normal, would be regular, and R to R interval would be regular, but they will have no correlation amongst themselves. As if there has been a divorce between the P and the QRS complexes, because first there was a routine that after every P wave you find a QRS complex, but now there would be a P wave independent of the QRS complexes, and the heart rate would depend upon which pacemaker is activated, whether it is a junctional pacemaker. In that case, the heart rate would be 40 to 60 beats per minute, and depending upon the location within the AV node, if the blockage is at the higher level, there would be narrow QRS complex, and if it is at the lower level, the blockage is located at the lower level, the QRS complexes would be broad. But if the ventricular pacemaker is activated, the heart rate would be 20 to 40 beats per minute, and it would be a broad QRS complexes. R to R interval would be regular, and P to P interval would be regular, but there would be no correlation between the P and the QRS complexes. And the treatment of the complete heart block is for sure temporary pacemaker or permanent pacemaker, depending upon the hemodynamic condition of the patient. Now, in case of the complete heart block, because both the atria and the ventricle are being depolarized by two very independent pacemakers, so the P is under the effect of SA node and is generating impulses at the rate of 60 to 90 beats per minute, or impulses per minute, or depolarization per minute, and P to P interval would be regular, and R QRS complex is being generated by the ventricular pacemaker in this very example, because there are broad QRS complexes, and R to R interval is very regular because it is being generated by another pacemaker, though less in number and broad in duration, but it is regular. But there is no correlation between the P and the QRS complexes. If I drop P, if I pull P on QRS complexes, you will see that there would be very haphazardness between the P and the QRS complexes, but P to P and R to R interval are very regular, and the treatment is permanent pacemaker. So here we see P is located where it should be, and QRS complexes are located where they should be, but there is no relation between the P and QRS complexes, they are divorced. Now you will have to put place in a mediator between these two, which can be a pacemaker. So this is a complete heart block, and depending upon the which pacemaker is activated after the failure of the door which allowed the impulse transmission from the atria to the ventricle, i.e. AV node blockage, when it is not allowing the impulse to go downwards, then the ventricle start sort of living at the behest of its own pacemaker, be it the junctional pacemaker, be it the ventricular pacemaker.